All right, thanks. It's so nice to see everyone. Sorry, I'm a little bit later, so we didn't get to do our talks in tandem, but I'm really glad to be with you. So I wanted to first start off, some of it will sound familiar from what Dr. Tolar was saying earlier today. I just wanted to tell you a little bit more about late effects, screening for late effects and how they overlap with DC, and then a little bit about our transplant trial that we're doing as a multi-center trial now too. But before that, I wanted to make one shameless pitch, if I can. I think I had this problem last year too. It's not advancing, Robin. Yeah. Anyway, I'll tell you the pitch without the slide. We don't really need it. So as you know, that some patients with DC, we've recognized that they actually have vascular problems. So blood vessel disease, pulmonary AVMs, or GI bleeding, et cetera. And a lot of us have recognized that, and we're getting a little frustrated that we can't actually figure it out. So one thing that we've done is basically try to get the attention of folks at our center who actually understand vascular biological disorders. And what they study, strangely enough, is they try to look for markers in urine and serum to try to figure out what the basis of the disease is. So given the opportunity at camp, the shameless pitch is if anyone would be willing to actually donate a urine sample while they're here, no blood or anything like that, you'll have to sign a research consent as well. But just try to find me, and Nancy and I will try to figure out a way to make it discreet and out of the way. And beyond that, you don't have to think about research enrollment at camp. I don't want it to be like that too, but it could be an opportunity if you're interested in participating. Okay, so there we go. That was the pitch. All right, so Dr. Tolar introduced this already today. The problem that we're trying to address in bone marrow transplantation is that of marrow failure or the marrow converting into a leukemic state. And I think he talked about the stem cell and how it is responsible for having a huge output of blood cells every day for all of us too. And so the theory is, at least one theory, is that patients who have telomere problems. Yes? Okay. Jacob's got good lungs. Okay, is that better? Okay, sorry guys, sorry about that. All right, so the idea would be that with telomere shortening, that the stem cell would exhaust and you would end up with this empty marrow instead of a nice, rich, productive marrow over here too. And so bone marrow transplantation can actually fix that by replacing the failed blood system, and also ideally eliminate the risk of developing a pre-leukemic condition or a leukemia as well. And the goal also then would be to regain a protective immune system. So that's a very basic goals of transplant. But the problem is that you try to have to do it without actually causing too much damage to the body and get back to a regular life as soon as possible. A conventional bone marrow transplant, as you may have heard, involves basically creating the space and eradicating the disease that exists. So if it's for a leukemia, then the chemotherapy that you would receive to actually eradicate the disease serves two purposes. One is disease control, but also creating space in order to allow the graft from the donor to actually get in. These agents that are typically used are DNA alkylating agents and radiation, which destroy the bone marrow. So in the process of having an anti-leukemic effect and also allowing immunosuppression and making space, they cause collateral tissue damage in everyone. They basically these are non-specific agents that hurt the liver and the lungs, and they cause the short and long-term complications. From the graft actually exerts an anti-leukemic effect if you need one also, but also facilitates replacement of the blood system. The downsides that actually account for late effects and toxicity in the patients are graft versus host disease, which you've heard about, an immune reaction not only against the tumor, but also against the normal tissues of the patient. And also in order to minimize the risk of this graft versus host disease, taking medications like cyclosporin, et cetera, to try to minimize that reaction, but those themselves have their own toxicities as well too. So these comprise the toxicities of a conventional bone marrow transplant in addition to the actual disease that you're actually trying to treat. And so this has been very problematic using those agents. What was recognized early on a few decades ago, and this is a retrospective by Sharon's group, is that there was actually a very, very high incidence of mortality. So the toxicity of the regimen most likely was causing a high rate of death early on. And then there was also an ongoing rate of death, so that there was a 60% survival at 2 years and 40% survival at 10 years, and with all the caveats of this being retrospective and by reporting specifically Dyskeratosis Congenita, these are unacceptable outcomes for this sort of disorder, and they're at least in part contributed by early and late effects of the regimen. So you've already talked about the acute toxicities of transplant this morning with Dr. Tolar. there's a huge interest in late effects, especially as early mortality decreases by using different conditioning regimens like Dr. Tolar was discussing. The biggest question is, how about later on? What happens to the body later on? What's the effect of the medication that you use? What's the effect of the graft going in? And how does it overlap with the disease that the patient already has to compromise quality of life? So the definition from Wiki here is a condition that appears after the acute phase of an earlier causal condition, when you hear about late effects, that has run its course. And this can be caused by the condition itself, the treatment for the earlier condition, or the combination of both. And this is very relevant in DC. And this is another way to think about it. Here are all of the different factors that may conspire to actually cause intermediate or late effects, something that affects you 5 years, 10 years down the road. So part of it is the disease, and that's very, very true in DC. So there are many, many organs that are already destined to become dysfunctional or have some compromise in them on the way into this disorder. The pre-transplant treatment. So what happened to what was happening to the patient, and what did they get? Did they get medications that were trying to fix the actual underlying bone marrow failure or some other complication, but meanwhile caused some toxicity that made the transplant worse or actually decreased the reserve in a particular organ? The conditioning regimen itself, as you've heard about already, and that I'll talk about more too, is a place that we can focus on, because even though we can't do that much about DC and its evolution and how much it changes from patient to patient, what the effort has to be is to try to tailor the conditioning regimen to not exacerbate the problems in the organs that are occurring. And then also, to some degree, if we can, and we don't have as much control over this, is how do you limit the graft versus host disease? How do you prevent it from actually setting in? And how do you prevent the complications of it afterwards too? And that's a very, very big problem. A lot of it, we say it's out of our hands because it depends in part on what kind of donor you have available to you. So another way of looking at this too, in terms of like what factors you can control and what you can use to actually predict the late effects, would be these factors that contribute here. Some of them pre-exist, of course, before anyone even shows up for transplant. This would be the schematic of a patient presenting for transplant. The other, the conditioning regimen here, the source of the graft, which contributes to graft versus host disease, and then the effects of whether or not graft versus host disease has set in. And chronic graft versus host disease has a major impact on quality of life and late effects and organ dysfunction later on. And I'll show you also how much it overlaps with the manifestations of DC. So here is the table that you guys don't have to read or memorize because it's in your DCO guidelines book. This is prepared by Drew Dietz. So here are typical allogeneic bone, so from somebody else, bone marrow transplant late effects. And they can affect every tissue. And so if you've had a bone marrow transplant for any disorder, the goal is, at an expert center, to follow the patient with careful eyes year after year after year to look for whether or not these are setting in for them. Are they the consequence just of the conditioning regimen and they come out of the blue, or are they actually getting worse because the patient actually has signs of graft versus host disease? So you can see these organs that are targeted, such as the skin, the eye, the mouth, they can be affected by GVHD. As well. You can have endocrinological problems because of the conditioning regimen that you got and how it affected the hormone production. Lungs and gut and liver, both from the acute toxicity of the conditioning regimen, but also insults from an immune reaction from the donor cells that you have. There are, of course, psychosocial impacts, both in the immediate term, the degree of social isolation and the difficulty in getting back to a normal life if you actually have to be restricted for infectious risk, or if you have physical limitations that don't allow you to do the work that you were doing before. And of course, a big one is that some of those agents have a propensity to cause cancer. So there's actually a heightened risk of certain types of cancer in the years that follow, sometimes many, many years that follow, in areas such as the blood. Again, it can be a cancer of even the blood system that's come in, or solid tumors, or of the brain, or the skin and epithelial surfaces like the mouth. And the reason why this is particularly important in DC, again, is that these are the same sorts of tissues, of course, that are affected in many overlapping ways in patients with DC. So a tendency for scarring in the lung and the liver, a tendency for leukemias of the blood, of the skin and epithelial surfaces as well. So on the one hand, when a patient is being monitored for DC in years that follow, their surveillance and their proper care actually is somewhat overlapping and quite identical to whether or not they're being monitored for a bone marrow transplant. But one of the things that this raises a huge degree of concern is that if any of these complications set in, or if the patient has been exposed to a toxic conditioning regimen, you worry very much and very rationally about these other factors actually being accelerated. And we don't really know what the answer to that question is. There's not a study that says that this particular risk has gone up this much by bone marrow transplant. That's a very hard study to do, and it's a very hard thing to quantify. But all of us have the sense that actually this is something just to be avoided as much as possible, the toxicity of the conditioning regimen and GVHD. So in bone marrow transplant, if you're talking about advances, trying to minimize those while getting the graft in is the biggest challenge. So, if you take this scheme, how do you actually try to mitigate, if you take a global sense? What things can you control? What can you think about, starting even before you thought about transplant for the patient, when they presented to you about mitigating late effects? So starting in the beginning. So both for the sake of the transplant and also for the sake of the patient's late effects, some of the factors that occur to us are to minimize the complications of the blood and the immune system defect that you're observing over time before they actually even show up for a transplant. Because the complications of those could actually make the acute part of the transplant more difficult and also the later parts of it as well. Minimize the toxicities of the medications that are being used to treat the bone marrow failure and the leukemia. So if there happens to be a leukemia that is set in or a myelodysplastic syndrome, there has to be a lot of attention paid to the agents that are used to eradicate that to allow the person to proceed to BMT. That's a very difficult situation. There's not a standard approach to that at all. And one of the questions that arises is then, should one be transplanted at an earlier age, before the onset? This comes up a lot. Do we do this before these other things happen? So we can't predict when other complications are going to come up for any given patient. So on the one hand, you could say, well, if this is going to happen, then we should do this sooner than later. And this has come up in the related field like Fanconi. And there's even some data that a transplant at a younger age actually does provide better outcomes. But it's a very, very broad and complex topic. And it has to be tailored to any individual and what you see in them at that moment. But the question legitimately arises from parents that they say, well, if these things are coming, why should we wait for them? Because it'll just make the transplant worse. And it's a tricky balance, right? Do something now to prevent future complications and incur a risk of near-term morbidity, sickness, or even death. So that's all before the transplant. During the transplant, this is what we've been talking about the most, is what can we do to try to actually minimize the toxicity of the actual conditioning regimen, spare the other target organs in DC, spare them from accelerated damage, but still get the graft in. Very, very tricky. And one of the things you've heard about is avoiding DNA damage agents. Using a best match donor. So, of course, we all look for the same donors in the same pools and see how best to match them. The good thing is that the donor pools have been expanding to some degree, and there's more options for patients, but some patients still just don't have a good match. And so it becomes a more difficult equation when you're talking about other sources of grafts that you may have already talked about, like cord blood, et cetera. But one thing I think is very true, and it's coming out in different diseases as well, is that with more intense matching, like more precise matching of unrelated donors, the outcomes with unrelated donors are starting to become much, much better, and in some cases actually approximate sibling donors as well. And then the other thing is tailor the rest of the supportive medications, including the graft versus host disease prophylaxis. Remove things from it that preserve the immunosuppressive component, but try to remove things that actually cause toxicity to other organs, especially things like steroids, like methotrexate, that are used very conventionally in GVHD prophylaxis, and think about that for other medications like antibiotics, et cetera. After transplant is essentially trying to balance. So the consensus would be that every patient needs careful surveillance at an expert center, both for the sequelae of DC and how they overlap with transplant. And this is best done by a center that has experience in seeing the manifestations of DC, because some of these can be very, very hard to distinguish, and whether or not it's an evolution of their disease underlying or whether it's actually a manifestation of transplant. And there are management distinctions to be made about whether you immunosuppress the patient or whether you provide some other form of supportive care. So that is an important thing to observe. In fact, there are some patients who've gone undiagnosed with DC and have developed a post-transplant complication that looks like GVHD and is called like GVHD and ultimately is just revealed to then be a manifestation of their underlying genetic disorder like DC. The goal, of course, would be to balance medical surveillance. You don't want to be in the doctor's office every day, preventive measures, lifestyle measures that the patient can take, and also their overall quality of life and getting back to function. So again, it requires comprehensive regular follow-up, surveillance and early detection of complications, and lifestyle choices of the patient and counseling for heart, lung, and minimizing cancer risk. So what I want to talk about in the rest of the time, though, is to talk about how to try to fix the blood without accelerating the other disease manifestations using a modified transplant approach. So going back to this slide about what the pros and cons are of these agents that are actually very, very effective in enabling engraftment, but also then have these downsides of collateral tissue damage. A lot of this has to do with leukemia, because traditionally that's what most of the transplants were done for. But when you're talking about a non-malignant disease and trying to approach bone marrow failure in DC, most of these are actually not applicable. These benefits are not gained by using these agents. You have no anti-leukemic effect. And in bone marrow failure, I would argue that you really don't need to make space. You actually need to suppress the tendency to rejection, but you actually know from patients they actually have a hypocellular bone marrow. There's like room already, in theory, for the cells to go in. And still, you actually, if you're using these agents to achieve the engraftment, you're incurring this toxicity. So this is where reduced intensity conditioning regimens come in. And so the idea would be to reduce these agents that cause non-specific tissue damage and introduce more and more immunosuppression, and ask the question of whether or not you were able to get engraftment. And so this is a very concerning thing. So especially when we're thinking about transplant for leukemia, you feel like you have one shot. You've got to get the graft in. Graft failure is a significant problem. So the tendency in the field is to err on the side of trying to do things that ensure engraftment. So I would say that there's a little bit of an addiction to these agents that actually have been used traditionally and have been thought of being necessary for engraftment as well. So there have been several papers on using reduced intensity conditioning regimens and a sense that things are getting better. And the best to highlight here is from Dr. Tolar's group and Drew Dietz, where this was the first prospective BMT trial in Dyskeratosis Congenita, which you talked about, I think, this morning. And it requires just a lot of praise, essentially, because it was a tailored application thinking about this specific disease and what's happening to these patients, and thinking about every element of the conditioning regimen, reducing the toxicity, including the GVHD regimen as well. So this is a highlight in the field. And so one of the questions we asked then a couple years later was whether or not we can actually eliminate radiation and alkylating agents altogether. So what is the evidence that this is actually necessary to get a graft in? So essentially, I've already told you that this is something that's held in the field as a requirement. But we wanted to ask the question whether you could get rid of them and still actually get a myeloid graft in. And there were a couple of theoretical things I'll tell you about for why that might be able to work. So eliminate these, use immunosuppression only, the backbone. So this is the regimen that we opened in 2012. This would be bone marrow transplant for patients with bone marrow failure, so not for cancer. So still, one would think that if a patient has pre-leukemia or leukemia, one might need some more intensity of the regimen to eradicate the malignancy there. So for patients with known or suspected telomere disease, and the outcome was to examine engraftment and disease-free survival following this regimen. And the theory here was mainly driven by this. Can we take advantage of patients who have a failing bone marrow and defects in their telomeres that might actually prevent them from rejecting the graft? So they have space because they're hypocellular, and maybe they won't be able to actually reject the graft that's coming in. So why do we have to subject them to this actual higher intensity and non-specific DNA damaging therapy? And then even though knowing what the benefit of these things long-term is very difficult too. It will take years and years and years to figure out whether it actually ended up making any difference. In theory, as long as engraftment was not compromised, the notion would be that getting rid of these agents would be a good thing. Basically, it wouldn't actually contribute to at least the short-term and intermediate-term damage to other organs from chemotherapy and radiation exposure. So this is the schema of the regimen. It's basically using this antibody alemtuzumab that depletes lymphocytes, and this other agent fludarabine, which if you look it up, it's a chemotherapy. So it basically does destroy dividing cells, but because of its pharmacology, it's restricted mainly to the blood. So it doesn't go and start destroying liver cells and lung cells as much as some of those other modalities do. And preserving this part of the regimen, which is basically using cyclosporin and mycophenolate, avoiding steroids, avoiding agents like methotrexate. In this case, I should point out, though, that this regimen, because we're worried about now we're taking away these agents, about engraftment. So different graft sources actually have a different likelihood to engraft. There's more risk of graft failure, for instance, with cord blood. It's thought in general, that's a very general statement. So in this case, we use an unmanipulated bone marrow graft. And the reason for not using another graft source like peripheral blood stem cells is that it feels like that is actually a heightened risk of graft versus host disease. That's essentially a consensus, at least in pediatrics too. So the patient would have to have a well-matched bone marrow graft from a related or unrelated donor. So the criteria for inclusion would be bone marrow failure, telomere disease, and a well-matched donor. The exclusion criteria is that this regimen would not be for someone who has evidence of pre-leukemia based on their genetics or a leukemia itself. And one thing that is interesting about this regimen is that we did not exclude patients for concurrent lung or liver disease with the notion that if they actually had those organs involved, this regimen shouldn't contribute. It might complicate the transplant, not to say that it wouldn't, but it shouldn't actually contribute to the failure of those organs. And the objectives were to see whether or not, of course, the patient's engrafted. And so we have definitions of how patients engraft based on their neutrophil count and whether or not they survived for short term. These were the primary objectives, and the longer term objectives were basically to try to follow patients for a long time, so 15 years, and to see whether or not there were problems in the short and long term with infections, with graft versus host disease, with late effects, survival. So this is going to take years and years and years to figure out, but that's the only way to try to find out whether or not it might have had a difference. And actually, it will still be complicated because it will be very, very hard to know what to compare it to, right? Except to say that this is what we've been able to describe. This is how it seemed to be in the past, and now this is actually how it's going. All right, so these are the results so far. So at our center, we transplanted 7 patients between 2012 and last year. They are 10 to 48 months out, and all are alive so far. So that's the survival curve. This is an unfair comparison to the historical data because the definition of the disease is different, the era is different, the conditioning regimens are different, et cetera, et cetera. But this is just a reference point from the same data that I showed you before about the short-term mortality. And this is the other primary objective, is whether or not the patients would engraft. So they can survive because they've been given a much lower intensity regimen, but did the cells actually go in? That's the real question. So these are the first 6 patients, and we had a parameter that said, which is a little bit standard in the field, is would the patients achieve a neutrophil count of 500 by 30 days? And the reason why everyone's so anxious about that is that prolonged low neutrophil counts have a higher propensity for higher likelihood of there being significant infection. It doesn't mean that you have to engraft by 30 days, even if you engraft later, as long as you've been able to support the patient. But for something to seem reasonable, and that's a gray zone, 30 days has been pretty much set in the past in other studies. So we're revisiting this because this ultimately doesn't actually prove engraftment in any way, as I'll show you. So the first 6 patients had neutrophil engraftment by day 30 and became transfusion independent and remained so. So the 7th patient, which I'll describe a little bit more, she actually had liver disease. And this is a patient that we actually wouldn't have transplanted traditionally. She had an enlarged liver that was called a cirrhotic liver with an enlarged spleen. So she had what was being called cirrhosis. And she underwent a matched unrelated donor transplant as well. And she had a very low absolute neutrophil count in blue and very low platelet count despite being transfused over and over and over again during this entire period of time. And this made us very anxious because it was starting to get out into day 45 period. And we were preparing for her second transplant, and we certainly thought at this point, especially given her platelet count, that she may actually have a problem with the spleen actually gobbling up the cells. And so if we were going to do another transplant, then we really should try to get rid of her spleen. And we weren't, this is not that surprising, but it was a little bit surprising, I would say, in how dramatic it was, is that she had her splenectomy, and within 12 hours, she basically had a neutrophil count that was over 500 and a platelet count that basically went up as well. So her spleen was interfering with potentially her engraftment, but also was actually truly consuming her neutrophils. And this is known from older literature when you look at patients who had CML and who had very, very large spleens. And so I think we thought that this would be contributing, but this is very difficult to do, by the way, on day 45 when you have no counts. So this makes us think a little bit differently, and we don't encounter that this much because we wouldn't have taken traditionally a patient like this to a transplant because of the degree of liver disease as well. So what about, whose cells are there? So what have the cells actually gone in? So we can track chimerism, so what percentage of the cells are from the donor, and here are the patients. And the first three were really straightforward, so they basically were all donor from the first time that we actually assessed them. And the other patients, we started to check earlier to see what was really going on, if you could actually detect a neutrophil count. And they can actually start a little bit lower, but they all eventually get to a very high level. So these patients are all full chimerism. The patient who had the spleen problem, she's pretty high. She's at 93%, but not fully chimeric yet. I think I took out the slide. There was one patient who, interestingly, had never had an ANC less than 500 during the entire time of their transplant after they got their graft. So that was actually a little bit interesting, because here you get to see now whose cells are they. So you can actually look now at the chimerism of that patient and see that in the beginning, that patient's cells were mainly his own. And then actually, by the time, even though you couldn't see it from the peripheral neutrophil count, that patient's cells became the donor without doing anything over the course of the next 45 days or so. So in the background, it's going to be hard to prove that there's a competitive disadvantage of the recipient's cells, but these are pieces of evidence that are in favor of that type of theory. So overall, 5 of the patients in this cohort had bone marrow failure and identifiable mutations indicative of a telomere disease syndrome. 2 others had bone marrow failure and very short telomeres, and we haven't found their mutations yet. 2 of the patients had transplant-limiting problems, one with pulmonary AVMs, who would have been excluded from a conventional regimen that we would have used, and 1 patient with liver disease. All were unrelated donor grafts, so related donor grafts would be perfectly fine, except these patients didn't happen to have sibling donor grafts. And our parameter is a 7 out of 8 match, or better. The median time to neutrophil engraftment was 22 days. None of the patients had acute GVHD, and we can talk about that a little bit. 2 of the patients had some hair loss and rash at around 6 to 9 months that were treated with topical steroids, and it was a little bit hard to distinguish whether or not it was chronic GVHD or not, but that's what we called it for them. And that actually resolved with the steroid cream. So in summary, from this regimen, which actually removed the alkylators and radiation, we had engraftment with minimal short-term toxicity in unrelated donor transplant. And again, traditionally, related versus unrelated donor transplant was a big difference. And I think that one of the things we're seeing here is that is actually starting to be not as big a difference if you actually have a well-matched donor. But I do also think that there's something about this regimen and these approaches, the reduced intensity approaches, which include antibodies, which actually diminish the onset of acute graft versus host disease. It's a little bit quieter in the patient. They haven't had as much tissue damaging exposure when the cells go in, and I think that's a major contributor to GVHD. One question that is going to be perpetually interesting to us is to wonder whether or not we're taking advantage of the telomere defect in patients with DC. Is this going to be specific to these patients? 3 of the patients are 4 years post-BMT, so at this point we do not expect them to have any post-transplant sequelae from their actual regimen. So that's a very, very difficult thing to say in transplant in general, because if anyone ever gets an alkylator or radiation, you always have to account for those agents having some effect in the long term. So these patients were not exposed to those. But in truth, this is the question now, is what's going to happen? How did it change things? Did it actually just allow other things to manifest themselves? So the DC surveillance is ongoing. The other thing I want to point out that is important here, and I kind of alluded to it, is this is the first series of patients in allogeneic BMT to achieve a myeloid graft without using these 2 agents, like one or the other of these 2 agents. So in some ways, you would basically think that DC patients, who traditionally have had a very poor outcome in transplant, by pushing the envelope a little bit, may be showing us that there is actually an opportunity for removing these agents from the transplant for patients with other related sorts of disorders too. So the current efforts right now is via the very clunky, but I hope you appreciate it. You probably have already gone through this, the acronym here, that it's actually the telomere repeat. So this consortium, we are expanding this to a multi-center trial. So this is one of the first prospective multi-center trials that are a treatment trial for Dyskeratosis Congenita with these centers. So that's active and open, and a patient's already been treated in Cincinnati. not as a consensus, but one of the things that occurs to us is whether or not to expand this to other bone marrow failure disorders. That will be tricky because there's a different biological principle there, and whether or not this might be able to be expanded to other graft sources. And recently we have had patients who actually don't have a bone marrow donor, a suitable matched, unrelated, or related bone marrow donor. So the question is, could you expand this to graft cord blood or other things like that? And the question is, and it's actually a completely unknown. I don't really know if it would work. So just to thank quickly, this is definitely, and this emphasis has definitely come out of the fact that this group exists. So this is the effort of the patient and family organizations and of Sharon and of Jacob very early on. And I think that I certainly wouldn't be doing that much work focused to this if I hadn't actually been coming to these camps. And so always start off by thanking the patients and the families, and then also the study teams, both at our center and also with our collaborating centers. And for the moment, this is actually funded essentially by philanthropy. So this is not actually yet something that has actually gotten federal funding, for instance. We haven't actually sought it formally, but we're probably on the way to be able to do it. But part of this in a very clunky sort of way ends up requiring a lot of resources at different institutions to maintain like regulatory oversight, et cetera. But ultimately, as you've seen, that you can actually execute a clinical trial on a rare disease with just local resources. So, all right, thank you very much.